Guys, welcome to Cath Lab number 1 again, where Anja did already a great job this morning. And we are about to start with our case. I have Piotr with me and Michele and Stefan and Christoph and Anna and
patient.
And of course a patient. And we have tons of support for the IVIS later on.
Yeah. Felix, maybe you can show us the
Marco,
case
so-
presentation and show us what
Yes,
you're going to do.
I'm gonna give it to Christoph.
Perfect, thank you.
And we're gonna prep a little further more.
So, hello again from my side. Michele, I need the slides. This one is about a 50-year-old male patient who is already a known ischemic cardiomyopathy with a known two-vessel disease, who has had previous PCI and multiple stenting in the past of the LAD and the RCA. This patient also has a broad cardiovascular risk profile with arterial hypertension, hypercholesterolemia, obesity, and is also currently smoking. Which will be challenging is the reduced ejection fraction of 34%.
Gibst du noch mal?
This one is the first angiogram of the left side, and you already see the retrograde filling of the RCA.
So.
Next slide, please. This one is yet another projection of the left system.
Yeah.
This third projection shows us that the left main has no significant problems. And this one is the right coronary artery, which has been stented previously and now is showing in the distal parts an instant restenosis, chronic total occlusion, and prior to that, a high-grade stenosis, also instant. Next slide, please. So overall, this procedure will be about this RCA, which has a JCTO score of 2 due to the bending and occlusion length. And that's it for the patient presentation from my side.
Impeller.
Okay, so
Okay, is the case clear so far?
we have seen the critical lesion in the mid RCA and then followed by CTO in the stent, and
Right,
not
so we
so
have the
disease.
subtotal. So we have the subtotal occlusion of the RCA and then the blunt ending of the blunt proximal cap. We have the bifurcation, which has been unfortunately stented. I've seen a picture of a relatively large RCA in 2017, so it's probably worth it. We were debating if we want to do if we want to discuss if we should do this as a protected case or not. There are some retrograde options, and there may be the difficulty of preserving the bifurcation or getting the bifurcation antegrately. So, because we have a reduced LV ejection fraction and we might run into a longer procedure, we said, okay, let's go for it. So plan is for us, we're just gonna implant an impeller, and then we're gonna do our setup shots, and then we can discuss a little further more what you guys think, or what do you guys think right now already?
So your main strategy would be retrograde first, right?
I'm probably gonna start integrate, and if we are lucky, we just go 2 to 2, or basically in the middle of the stent, and then we are more or less done. But these instant CTOs, they might be challenging or surprising, so we may run into a longer time period. And if we decide to need support in between, it's most of the time not a good idea. So why not doing it up front, and then if we have to go retrograde, we have support and we have time to go retrograde.
Felix, I think it's this is Michael here. Hi. I think it's a very good
Hi.
decision to go for safety in this patient. I mean, it's a bit more of technical how to say, a higher technical level you want to achieve now also for the procedure. But if you're familiar with it, I think it's better for the patient, of course. Any other suggestions? Who would start with an impeller in this case or not? From the
Yes,
panel,
perhaps
maybe?
in this case we can discuss the stage procedure. If we have a success in the antegrade procedure, we can leave the impeller in the box, and if we must have to change in the retrograde way, then we go to the impeller procedure. It's another option if we want to avoid this big femoral vessel access.
Felix, have you heard this comment, or maybe starting?
Yeah, I heard that.
What do you think about it?
have-
It's a matter of experience or also personal estimation, either being safe upfront or making smaller steps
Impeller start.
before.
So, I mean, we have an EDP of above 20 with a 100, yes,
Yeah.
with a 100 systolic pressure. So we crossed the four times LVP is larger than the systolic pressure margin, and of course you can stage, but first we are here to open the vessel and not for showing how to stage a procedure. Second is the patient is fairly young, and I don't want to put him onto several procedural risks. And on top, we did a micropuncture with a micropuncture set. We did a nice angio. It's fairly possible. I don't know if you can appreciate the angio already through the micropuncture set. So it's basically a clean vessel. So if it's possible, why not? And we know if we run into trouble, regardless during the procedure, and we have to switch to a supported case. That's most of the time, even if you're very, very fast and very experienced, not enough time to place an impeller in between.
So Felix, you inserted the impeller already in the LV, is that right?
Sechsfensterschleuse. Yeah, it's running. We have a
running
support
already.
of 3.5 liter right now. It's running.
Sure.
I don't know if somebody stopped the time, but it was probably not a long thing to.
No,
get in.
you appear really relaxed and talk to us, and meanwhile it's inside.
One additional question in the femoral access. Do you do their pre-closure system now, or
Yeah, so we
leave it
have
alone?
done an ultrasound guided puncture with a micropuncture set.
Yeah.
Then we pre-dilated with a 6-French sheath, and then placed a ProStyle. If the ProStyle is, let's start with the AL first. Und packt ihr mir den Pick hier noch rein, bitte vorne. So if we leave the pump in, we just use the ProStyle to fix the long run sheath a little more to prevent bleeding. And if we take it out, we just close with that ProStyle and a 6 or 8 French angio-seal, and that's most of the time working really fine. And then we have basically no bleeding issues. So, and the bailout is always a 14 French Manta, but because of Protect 4, we are limited to ProStyle and angio-seal,
Muss die linke.
and it's working
Ach so,
relatively well.
Nicht mehr. Das war er gewesen.
Felix, all right. Let's just talk a bit about the next steps. Maybe we can give you some time to prepare everything for the dual injection and all that stuff. And meanwhile, we go to the other lab, to Daniel, and then coming back to you. What do you think?
Oh, I thought they're done already. Okay, say hi to them for me.
Yeah, well, that's what I wanted to hear from you, but unfortunately not. But what do you think about my suggestion? We are going to Daniel and then coming back to you. Is that fine?
Yeah, just go ahead.
Thanks.
Go ahead, and then we make some nice setup shots for you.
Perfect.
See
Thank
you in
you.
a bit. Hello, welcome back.
Ralf Birkemeyer. So we changed panel in the meantime.
Hey, Ralph.
So
You're
perhaps
kind of you could speak a little louder if you like.
It's a problem here,
Tough to understand you guys.
so I try my best.
Okay.
So can you give us a wrap up of what you did in between?
So, I mean, long story short, I think it was a good idea to do a supported case. We are, as you can, do you see the live picture?
I think so, yeah.
So in the live picture you can appreciate that we had to go vitro. And we have been a little further than this right now, but we lost the wire position due to the extensive knuckling of the retrograde wire. So now trying to go back and do a rendezvous or tip-in. You see there's a 7 French guide extension already within the stent in the proximal part, but the downside is, we can show you the other pictures. We have done a view. So I think this is somewhere, so this is how we got more or less integrate, but like in the third of the RCA, this is the RCA, we are leaving the stent, or we're basically below the stent. So there's a kink in the stent, and we were not able to resolve this, not with any wire, and it was very, very hard. We tried a parallel wiring with a microcatheter. But so in the end, we had to switch strategies, which was basically then a retrograde approach. If you go for retrograde, we had some okay epicardials with some bending. So we dilated the proximal part already. And then here you can see basically the epicardials arising from some whatever D branch or basically septal branch. Well, it looks a little like going at least at the septal. And then we did the tip injection later on because the suo didn't want to go. You see that nice kink there, which is like an S curve. And then we knew more or less where to go. And this is the septal, or this is a crossing basically with a suo. And then it went relatively far already, basically down to the bifurcation. It was a little surprising for us. And then we are basically stuck there in this 90-degree angle bifurcation part. The integrate wire is still extra. So now we are trying to solve the problem with the retrograde. So again, we passed there for one time, and then we advanced the guide extension integrately until a certain point. But somewhere there we left the system, so right now we want to just re-enter, and I would like to do a rendezvous and swap to an integrate approach, because I don't know how long that epicardial will basically last. Yeah, and that's where we are right now. The patient is having some trouble in between. He has chest pain. He had a pulmonary edema. We are treating that already, some with a lot of medication. Right now the patient looks like he is more or less sleeping, which is good. And yeah, this is where we are right now.
So a really tough case in many aspects.
I mean, if you are lucky and you just enter with the gladius centrally, a stent, CTO, then you're lucky. But if there's some reasons for the stent failure in between, it can be, of course, troublesome. And again, the caravel here retrogradely is not working well through the stent struts. And yeah, so this is where we are right now.
Perhaps I missed it. What is your retrograde wire at the moment?
That's the Gladius EX. The beauty of the Gladius is that it tends not to be too fast under stand strut, but right now it looks a little like this, especially in the distal part or in the more proximal RCA part. And that's actually the spot where we left the system anterogrately. So that must be a relatively tough part. We might switch back to a Miracle again. All the other wires have been too soft so far. We might even try again a Gaia retrogradely, just because you can steer it a little better, but you can appreciate a nice knuckle. But
I'm not sure if I can see it. Did the retrograde microcatheter pass the kink in the stand?
oh, it's actually in the stand. It's basically within the bifurcation. I can give you a quick cine. Just have to check my. Sorry, I have to check my retrograde. Okay. So we are basically in the stand, but having trouble to get around the corner there and then further into the distal RCA. So that ostium is giving us a hard time. I don't know what the exact stent modality was here in the bifurcation. If this was the primary stenting or it was a side branch stenting. But as you can appreciate, we are most of the time stuck in some stent part.
And it might well be that the stand is a little bit underexpanded there. That might be the reason why.
I would assume so. I think this is the mode of failure here in this case. And again, it's really, really tough to advance some wires through the stents here from both directions. So eventually we're going to get there.
So Felix, I think we let you work a little bit more and switch back to the other room. They might have finalized by now.
Ralph, can I just say something?
We have a question, sorry.
Felix, this is Jarno
Okay.
Oliver Kroh now.
Yes.
We're going to have a debate today.
Oh, I thought you were not coming because you don't want to
I
do
wouldn't
the
miss it
better
for the
against
world.
me.
Just had a detour in
Okay,
Amsterdam
okay.
overnight. Anyway, I just
Oh,
thought
awesome
that
that you made it.
these are very difficult cases when you have to go retrograde through here. What would you think about getting a zoomed-in image, taking possibly a high frame rate zoomed-in image, using also high pulses to really see how the stent looks as you're going in, especially if you're going to go with a Gaia?
Yeah, that's definitely a good idea. I mean, we have used some radiation already. About the 12,000 right now. Yeah, that's definitely going to be a good option once we have to go for a steerable wire. Right now, I have been further with the wire than this here. I basically had the problem that the Gladius was forming a knuckle and I was not able to advance the knuckle into the guide extension, and now I switched, and then I wanted to switch back to a new one, and of course then we are there that it's not moving that much anymore. But it's definitely a good call. Give me a miracle again, and if this is not going.
So Felix, I think we let you work a little bit and we switch to the other lab. They
Okay.
might have finished by now.
Are you back?
We are back. We're just waiting for you
Oh,
to hear
that's
us.
beautiful. Welcome back.
I think you made some progress.
See, we are dilating. Eventually we got. You can show Michele. Eventually we went a little back with the Gladius EX. So we did so this is where we basically ended up with a Suo, which is beautiful, but it's basically an ostial occlusion of that one further, of that PL branch. So we're basically not able to get further. So that, and then this is where we actually went in and then went out again. So we had to bring in the guide extension integrately, what we did. And then we were basically pretty good with that knuckle, but we were not able to enter that knuckle into the guide extension, so we had to go back, and then we got stuck in some side branch or in some stent again. So we did a Carlino injection, and then we went back with all the system and started over again a little distal to the beginning of the PL stent, and then we were finally able to re-enter with the Gladius, and then one further. And then can go one back. Yeah, so I probably wasted 10 wires or so at least, just because we got stuck in all the different stents. So this is the passing into the guide extension, and then because I didn't want to stress the epicardia too much, we went down with the Integrate Turnpike, and then did a rendezvous, and one further, and then we swapped integrately, and now we have the wire retrogradely, and the cover is still in place, but then integrate Grand Slam, swapped that out, ballooned with the 2.0 balloon, and now you can appreciate the nice iris we did if you want. Can you show the iris, please?
I could do another inflations.
Can you see the iris?
Yes, we can.
Okay, so you see a distal diseased vessel, that's the PL, distal PL, then the stent starts, that's the, so heavily diseased vessel, this is where the stent starts. The size of the stent is actually distally not that bad, but the more proximal we had, you see that it's a huge mismatch. We measured that the stent is 2.5, but the vessel behind it, it's basically a 4.0 vessel. So now we know the mode of stent failure, and we are trying to balloon ourselves up and fix that. The additional thing is we have still the occlusion. So we dilated with 3.0 now. We have still the occlusion of the PD. So, but we have a dual loom still on the shelf, and so we're gonna try to open that one up. I might gonna show you an angio. Just it's all stented anyway. So so this is where we are right now, which is not too bad, I would say. But especially the Ostil stent of the Ostil PD has some difficulties. You see down the road where actually we left the stent and had the knuckle before, and of course the reason why we were not able to cross the mid part was that partially collapsed stent from the mid to distal RCA or in the distal RCA. So what we're going to try to do now is we're going to try to puncture the PD, trying to preserve the PD, and then dilate ourselves up with high pressures, maybe with IVL, do another iris imaging. You have seen it's very beautiful, and this was only the half speed, so you can do a 10 millimeter per second speed, then you have the full vessel in more or less 10 seconds. And yeah, then we're gonna decide if everything opens up well and stays open. We probably just go and DCB the whole thing.
Hello, Felix. It's Jure Avramovic here. Ciao, Michele. Do you hear me?
Yes,
you said about the DCB. I'll be a little bit provocative over here. Have you read the guidelines, the new ones?
Yeah. I have to stand all way.
Yeah, you have to
again.
stand again
about this.
all the part. So yeah, I also agree with you that I would also DCB this, but
If you let
really,
me rotablade the whole thing up front, I might do that.
yeah,
But
sure. But I think we are not the only one who were, let's say, amazed by this thing in the guidelines this year. So yeah, this is because of few studies. But I don't know. What do you think in this setup? You know, according to the guidelines, which is
I mean, I love DCBs in stents, but honestly, for DCBs in stents, you're always encountering the problem of the stent failure within the DCB. So if we are choosing a too small stent, like in this case, a DCB will not solve the problem. So this is why maybe additional stenting after extreme dilatation might be an option in some cases in osteo disease or something. But if you have this length here, I would probably try it with DCB only, and if this and have the patient come back, and if this is not working, I would do like spot stenting where we know that the stent is not opening up or is not going to stay up because there is no still calcific disease behind it. Can I get the workhorse wire again, please?
Yes, actually, I think there's also common sense and not only guidelines. And to put another stent, an under-deployed stent, is not a good option. Yeah,
completely agree.
So what will be your next step then?
So I'm still missing the PD branch. We dilated with 3.0 now the whole way to the distal stent. So I'm gonna try to get this integrately with the turnpike. If that's not working, we still have the dual loom from the beginning. And if this is not working, I have all the gear for going retro. So I could even go try to find some septal, even though they have been not visible in the beginning, and try to get the PD branch retrogradely. I'm not sure if I'm going to do this. This might be something you can stage too, but we will see. The patient doesn't like the whole procedure anyway, so he has a lot of furosemide and diazepam and morphine, and yeah, was in pulmonary edema in between. So we had good times here.
But now he's stable?
Yeah, everything is stable. I mean, this is obviously not a case everybody would consider using protection, and of course I always advocate against overuse, but in between I was relatively happy that I have the whole thing in. Gladius EX, please.
Yeah, that was a good choice to put.
Especially to unload the left ventricle, right?
Yeah. Which guide were you using now to enter the PD?
So right now it's my turnpike spiral I've been using from the beginning on, and I'm gonna try a Gladius EX again. The beauty of the Gladius is, especially in stent and bypass CTOs, it has more or less a round tip, so it does not tend to go under the stent, even though we have experienced this in every part of this long stent area today. So I'm not entirely sure if it's going to be very much helpful. Right now we left probably the stent part too. It's just going too well. So we are probably next to the stent, and yeah, we might have to use. Yeah, you can appreciate it very well, right?
You could
so
use something harder, I think, over here. Maybe if this doesn't work. Huh.
Yeah, of course, but I try to not use the hard things first. But of course, I have to work myself up to the harder stuff. And you see that actually there's a lot of room, even though somebody thought in beginning he would have stented the whole vessel, but obviously he didn't stent half of the vessel because it's just a very, very...
Felix, may I ask about a very simple thing, and could you a bit explain about anticoagulation and antiaggregants during procedures like those? Because there is, of course, it's also impel, and this is a big sheet and everything, and then you are doing quite, let's say, nice, very nice, but of course also aggressive work. Do you think that we need some additional, some GP2-BCA blockers for so long and actually procedures and also long lesions, or it is enough to use just regular what we do like prasugrel or ticagrel or even clopidogrel and aspirin?
I mean, I like to have a little more, so I usually load my patients after that with ticagrelor, but other than that, especially in the procedure, I would just stick with heparin because you could theoretically antagonize it if you have trouble with the groin. So I would not overdo it, especially not if you have the 14 French in there. I mean, it's fine right now. We have a little hematoma on top of the sheath, but so far it's relatively well. We have the single access on the groin, and we have the 7 French for the right in the arm. So, I mean, you should do, of course, single access because then you're just saving one additional access.
Yep.
And you make the most out of the 14 French hole you're doing anyways. But other than that, I would try to keep it as conservative as possible. I would not overdo it with anticoagulation. Can I get the miracle again, please?
So, Felix, I think we grab a coffee now here. I'll let you work a little bit and then we will back
perfect.
with a cup of coffee.
Save me one.
Thank you. We take a break for
See you later,
10 minutes.
guys.
Yeah? Felix? Hello, Felix.
Hello.
Sorry for being rude.
So we just want to show you the IVUS. Welcome back. I hope you had a good coffee. So, mach nochmal ein Einzelbild bitte, nicht das. So we managed to cross into the PL branch with the gladius eventually, and then this is the IBIS run right now. So we dilated the whole PD already with the 3.0 NC balloon, which went relatively well. And here you see we are in the stent, but the stent has been initially too small again. It's more or less a 3.25 vessel than a 2.5 vessel. And then, of course, we have been dilating already. And this is the quick run, so we have been relatively fast with it. So we probably need to post-dilate all this again. Kannst du hier nochmal messen, bitte? So the vessel is here more a 3.5 than a 2.5. So the stent initially has been too small, probably, so we know what the mode of failure is. Go further. Oh, geh nochmal zurück, bitte. So here I'm not entirely sure if there's maybe even a stent gap, right? Which is on the proximal PD, close to the entrance into the distal RCA. Weiter. And then there's the next stent part. And now we're going to see the bifurcation in a sec.
So you didn't need a dual lumen catheter to enter the PDA?
No, fortunately not. Somehow the gladius went eventually, but... And then here we post-dilated already everything with the 4.0, so now you see that the stent is actually enlarging and close to the original vessel size, especially in the proximal part. We're probably gonna post-dilate everything, and we're gonna DCB the whole thing, and probably gonna do kissing in the bifurcation. So this is the angio where we are right now. You see that there's some moderate disease still in the bifurcation, so I'm not entirely sure if I want to leave this all. We're going to look how this looks after DCB, and then we're going to see.
In this kind of cases, would you consider to use IVL in some parts which are underexpanded?
I wanted to show you one thing which was probably the cause of the whole. This was the first dilation with the 3.5, so this is where the problem probably was. Can you see the balloon, Angio?
No, we're still on IVUS. Yeah, no. Now we can see it, yeah.
Okay, can you switch back to the Angio?
We see the angio now.
So this was the part where it was giving us a hard time, where we always deviated and exiting the stent. And this is a dilation with whatever 18 atmospheres, and with 20 atmospheres it eventually opened. And this is probably the mode of failure in this case. If this would have not been opened, you can always think of a ultra-high pressure balloon or IVL, of course. Officially, we are not allowed to do IVL in stents, but it's working relatively well, and especially it's giving us the opportunity to treat calcium, even though it has not been treated upfront stenting.
So Felix, is this in the stent, in the gap that has no stents maybe, or no? So did you identify the segment where is this gap?
Yeah, I think this is the case. I think that's the part which looks a little odd here in the angio. Shortly before the bifurcation. So I think there's a short segment of not where this small tiny side branches, a short segment of no stent there, and we might have to consider stenting this part. I got a DCB, all the PD and the branches and the bifurcation, and then gonna look how it looks afterwards. A long DCB, as long as you have 275.
I mean, great job otherwise.
Yeah, yeah.
It was really tough.
It's very good, yeah.
Yeah, please don't stand too much in an RCA. It might give you a hard time opening it again. So DCB a lot, or use a scaffold maybe. Don't use so many stents there.
Yeah, I agree with you with that. I just provoked you before a little bit because we had a fight in Basel, you remember? But anyway, which DCBs you preferred actually? Do you use also sirolimus DCBs, or you basically stick to paclitaxel?
I mean, we have been part of Solution de Novo, so we're going to see what's going to come out there. We have seen basically not a big difference between the SCB and paclitaxel coated balloons from Brown. Honestly, I think most of them are working. I'm not sure about some special balloons, but most of them we have in our hands are working. And I think it's a minor issue of which one to use. They're probably all working, and this is a case I would definitely do an angio control again to determine if this was the right decision to just DCB. Especially looking at the guidelines right now, right?
Yeah, sure.
May I put one really provocative thing, because you asked about the DCBs, but in past what we used, but it's of course it is many years ago, and now I didn't see even on shelves these perfusion balloons. And I guess that actually if you really want to elute vessel wall with drug, we would use a drug-eluting perfusion balloon, because then you can leave this for 5, 10, or even 30 minutes. And if you look back on when we really fight about balloon angioplasty, then actually the restenosis rate was much less if you open balloon, and balloon angioplasty was more than 20 minutes. It's just
my point. My point is that it's not just about 20 minutes.
But it's true. I mean, I've seen cases where you actually balloon for 30 seconds in a proximal RCX, and the patient has this flat line, and you're hardly getting your drug there. So having especially in the proximal part,
I spent 10 years with balloon angioplasty, and actually it also came from Germany. There was a big balloon concept that we make with big balloons. Dissection doesn't matter. If you wait a bit, if vessel is patent, you leave and then it's healed, and you need not put the metal, what you see in here, there's a metal, 2.5 metal, it's killing patient. You can't do nothing with this afterwards. For this reason, I guess we should always be very, very careful actually to use, we use stents, no question, but actually also to use the metal stent.
Yeah, but I agree. It's also a concept of like modern PCI. You dissect the vessel, and if the vessel is big and the flow is okay, basically we leave it like that. You put the DCB and the vessel heal itself. You get a net lumen gain. And especially I agree with you that a stent, which is smaller than 2.5, should not be put in a vessel. I mean, it's like...
No, but you mentioned this modern. This is quite interesting. It's modern concept. It's like fashion. It goes and comes.
Yeah. For me, it's a little bit like Back to the Future. Yeah.
Yeah, sure. I've seen people putting like direct stenting. I'm not really old, but in the beginning of my interventional career, we were directly stenting everything.
Yeah,
because it was like we work like this. Then I did a fellowship in Italy. Then we were post-dilating everything till 30 atmospheres. So it was a different concept. Now we are pre-dilating extensively, you know, once again. So as you said, Back to the Future. I mean, and yeah, so maybe we'll find another concept in the next 10 years. Maybe we'll inject some solution that will, you know, clean all the vessels as we do at home.
Yeah, this is still something. We still have almost the same drugs on the balloons in whatever 20 years. So we might have to consider to find something else, something cool, some RNA or something.
So thank you, Felix. At that point, we will switch to the other lab now, and we come back later on to see the final result. Yeah. Again, a big applause.
Thank you guys for joining again, and sorry that it took a while.
Hello, Felix. We are back.
Hello, welcome back. So we have done some artwork here, and this is our DCB result so far. You know, you see that the proximal ostial RCA is not stented, so this is gonna get some love with the 5.0 NC balloon now. Then we're gonna stent that ostial part, but we are pretty happy with the distal result in the stent, so we're probably gonna leave it. We ballooned everything with 4.0 and did a kissing in the bifurcation with 3 zeros, and we DCB'd the whole stent.
Great. Looks very nice.
And again, we're just gonna do the proximal part with a short stent, just the entrance between these two branches, and then we're gonna check if what our retro gear has done to the small tiny collateral, and we are already weaning the impeller, and we're probably gonna try to explant it in the cath lab just to make sure that there is no
you showed us that the distal
no additional harm.
That the distal stent was really underdeployed. Was it implanted in an acute coronary syndrome? I think sometimes it happens when you implant small stents in STEMI situations and you underestimate the vessel size.
Yes, definitely. And you know, we are here with 5.0 in the proximal RCA. We have dilated the whole. We had dilated the whole stent of the RCA to the bifurcation with 4.0. And I think that's what we all have learned in the past. Now that vessels seem to be bigger than we have been thought before, and this is the strength of IVI, and we are seeing actually how big a vessel is. And then you can blow up the balloon with whatever pressure and the 5-0 without any fear that you're going to rupture.
So I think we accompany you
So stand-
during the last steps of your procedure.
5-0, 13, 14 stand. 5-0.
Oder 4-5er. 4-5-12, 4-5-16.
16. Maybe with a.
So who would have standed more here?
We have.
Felix, may I ask you the question, because you know, and all CTO guys know that when patient coming back, the arteries usually looks much more better, because now it's endothelial function is depressed or practically no endothelium there, and then in 6 weeks, 8 weeks, even in a couple months, it's what we call restoration. It's coming back, and actually it's a function, and then it looks completely different, and usually much more better. Do you think that we always need to make a picture? What this is a really old guy, the Hustler, says that maybe we should go for good result, not for 100% picture what we can get in end of the operation or procedure.
I mean, here I just want to send the entrance just because there's a dissection on the entrance of the stent. I think we get the good picture after after a couple of time when all the side branches are preserved or the side branches are perfused again. So I think that's part of the deal, that we actually need a little time to get some restoration. The CTO didn't develop in a day, so we cannot expect all the function to come back in a day, right? And I would not overdo it, especially not if you have such a long stent area already, and you have seen the great cases this morning done by Anja, and you could even have thought about not stenting that much and say, okay, the rest might develop, and if not, it's you can still solve additional issues. So I think I'm a big fan, or let's say the other way around, I'm a big fan of having another look a little later on and check if whatever we have done looks like or gonna be a long-lasting thing.
I think that's a wise approach, yeah. And my thinking, you asked what we would do if we would put in a lot of stents. I think if what R stands for, they treat dissection and they just treat recoil. And if we don't have a flow-limiting dissection, and if we don't have a lot of recoil, we don't need a stent.
Absolutely. How it's from where it's coming? Actually, it's coming from bare metal stent error, because then we really try to avoid the long stents, and we very often to leave a long interventions just by balloon, or maybe even what also Felix mentioned, spot stent. And then we see actually that if patients come back in 6-8 weeks, then you can, or even maybe for longer periods, then you can fix this with very short one. And that's why I guess it is really important. That's what you says about the diluting balloons. The question is that we really need to see a real dimensions. For example, in this particular case, you know, there's 4.5 vessel. We can't to fix this with 2.5 balloon. It's impossible.
Completely right. And so I think we will learn again to skip the stent in some instances, yeah. And we see now, after we have good drug-eluting stents, that they are not as good as we thought. You have a yearly target failure or target lesion failure rate of 2%. It's just a foreign body reaction, and so we have to get rid of this stuff, yeah.
A lot of the stent failures in the studies, I mean, because there is no strict protocol how to do PCI. Because, you know, some people do this first, this next. Some people have achieved a good lumen before they implant a stent, before they implant a drug-eluting balloon. And this, I think, is the cause of the problem, why we have a lot of, not a lot, but we have very different results in TLR in different centers if we look to one study.
Ready for a duel?
So I think at that point, we will say goodbye. Final goodbye now, yeah?
Bye.
Thank you very much for the
See you
case and
later.
big applause.